Welcome to AETCM, the emergency medicine channel. Today let us discuss about organophosphate poison. It is one of the most common insecticide poison in our country. There are different types of organophosphates available in our country. Some are nerve agents. They are not routinely used in pesticide use or insecticide use. They are mainly used in warfares. It is not at all available for a local purchase or use. So we no need to discuss about that. Insecticides, different types of insecticides are there. Dimethyl components, diethyl components, dichlorvas, chlorpyrifos, phenethion, malathion, parathion, quinalphos. So many types of poisons are available. They all have same type of clinical feature. These all clinical features are due to these OPs are capable to inactivate acetylcholinesterase irreversibly. That is the main problem. This irreversibility is time dependent. So initially we can reverse it, but afterwards it will become irreversible. This will lead to accumulation of acetylcholine at cholinergic synapses. So the acetylcholine levels will increase in cholinergic synapse, and that produces all type of clinical problems. So acetylcholinesterase enzymes are inactivated. Acetylcholine level at cholinesterase synapses are going to increase due to accumulation of this acetylcholine. So we have already learned that OPs can irreversibly bind to cholinesterase. This is a time dependent problem. So early phase we can reactivate them by drugs or whatever it is, but as time progresses this will become irreversible. This is called as aging. Okay, that is a very important phenomenon in OP poisoning. So whenever you want to treat the patient, you have to treat fast, otherwise aging may occur and the enzyme will become irreversibly changing to inactive form. But many patients, what we are in our practice, large amount of OP consumption, even if we treat with the proper medication, the patients take longer time to recover. So the time is also important, the quantity also important. So both are very, very important when we are managing. Both the knowledge about both the quantity and time is very, very important when we are managing the patients with OP poisoning, so that we can prognosticate better than in a better way if we know the time and quantity. And there are different stages. One is acute cholinergic phase, intermediate syndrome, delayed polyneuropathy. In acute phase, it starts in minute, usually within 1 hour. It lasts up to 48 to 72 hours. OPs can produce muscarinic, nicotinic and CNS effects. Muscarinic effect, all secretions are going to increase. So you can get increased sweating, increased salivation, increased lacrimation, increased urination, increased bronchial secretion, pulmonary edema. So all secretions will increase during muscarinic activation. Meiosis, constricted people, it's a classical finding seen in patients who is having OP poisoning, constricted people. Whereas when we are giving atropine, this will become dilated. So atropine toxicity, dilated people. OP poisoning, it is constricted people. Bradycardia is seen in most of the cases, but some patients due to nicotinic action they can have tachycardia, but that is there is a rare clinical finding, not a routine finding. So whenever the patient is having smell of alcohol or OP, bradycardia and constricted people, you have to always suspect OP poisoning in our country. Heart blocks, hypertension are very common. Bradycardia and hypertension are the usual presentation of patients who is having OP poisoning, that is due to muscarinic activity. But some patients, around 20% of the patients, they can have tachycardia and hypertension, that is due to nicotinic action, that we'll see afterwards. Sympathetic overstimulation. So you can remember the muscarinic signs by two mnemonics. One is sludge, other one is dumbbells. salivation, lacrimation, urinary incontinence, diarrhea, diaphoresis, GI upset, that is again diarrhea or abdominal discomfort, emesis, all secretions are increasing. Dumbbells, same like that, diaphoresis, diarrhea, urination, meiosis, bradycardia, bronchospasm, excess lacrimation and salivation. So, whichever way you can remember the clinical findings, you can remember, but at least sludge, BBB or dumbbells you should remember. Now, I already told these patients can have some clinical finding. From that, we can tell that it is cholinergic muscarinic toxidrome and cholinergic nicotinic toxidrome. But only problem is the same type of toxidromes are seen in other conditions are there. Other conditions also, like cholinergic muscarinic, you can remember sludge or dumbbells. It is seen in carbamates, it is seen in organophosphates, it is seen in some mushroom poisoning, physiostigmine, pilocarpine, pyridostigmine. Cholinergic nicotinic toxidrome is seen in black widow spider bites, carbamates, nicotine, organophosphates. So, if you can remember this type of toxidromes, you can easily make a quick diagnosis in emergency room. Then you can correlate with the investigation profile. Now, pinpoint pupil is one of the classical finding you see in patients who is having OP poisoning, but there are a lot of other causes for pinpoint pupils like Horner syndrome, hemorrhages into pons, cluster headaches, aphakias, OP poisoning, opioids, then nicotine cigarettes. So many other causes are there. So, when we are analyzing a case, if there is associated clinical finding, then this finding like pinpoint pupil has got a major value, but pinpoint pupil alone will not have any major value. You have to associate with other clinical findings, like for example, somebody is having pinpoint pupil, he is having one side weakness, then it is a pontine hemorrhage or pontine lesion. Somebody is having ptosis with pinpoint pupil, then it can be Horner syndrome. Somebody is having bilateral pinpoint pupil and he has taken some unknown drugs, then you can suspect morphine. Somebody is having pinpoint pupil, smell of kerosene or alcohol, then if the patient's all secretions are increased, then you can suspect OP poisoning. So, like that you have to correlate with the other finding. Now, nicotinic reactions, nicotinic effects occur via acetylcholine stimulation of receptors at the neuromuscular junction. In that, muscle twitching, fasciculation, muscle weakness, respiratory paralysis, these are the most common findings. So, when you examine the patient, you can see the chest muscles, like you can see the chest wall muscles and lower limb muscle, where the muscles are very prominent. You can either tap on the muscle or ask the patient to take deep breaths so that you can see the fasciculations on the body. So, this is one of the earliest signs of OP poisoning. Whenever we examine the case, we have to always document that smell of the poison, pupils, secretions, lung crepitations, then fasciculations. So, fasciculations are very important in OP poisoning. So, we have to examine and document it. Now, some patients can have hypertension or tachycardia. This is seen in around 20% of the patients who is having OP poisoning. So, but if you see the toxidrome, most of these patients are coming with bradycardia. That is one of the important diagnostic feature of OP poisoning. Bradycardia is a main diagnostic feature, but around 20% of the patients can also have tachycardia. And if the patient receives atropine, again that atropine itself can cause tachycardia. Now, CNS nicotinic and muscarinic receptors can produce problems like respiratory depression, anxiety, restlessness, weakness, confusion, convulsion, coma, but all these things also can be produced by atropine. So, when you are treating the patient with atropine, higher dose of atropine can produce anxiety, restlessness, weakness, confusion, convulsions, coma, agitation. All these things are common in atropine poisoning also. That is very, very common when we are treating patients with OP poisoning. Slightly overdose of atropine can produce all these complications. Cardiac arrhythmias, QT prolongation, all these things also seen in OP poisoning. Respiratory system examination is very important because initially itself patient can have aspiration pneumonia. That is very important. Many patients mix this OP with alcohol, so many of them can aspirate these contents while doing stomach wash. Also many can aspirate, and some patients after 1 or 2 days they develop ARDS like features, and lot of lung crepitation can also produced by the OP that produces bilateral crepitations. So all these things are very important. You should remember one important thing is the best way to identify atropinization is absent crepitation in the lungs. Lungs should be dried up. That is the best way to identify atropinization in OP poisoning. Whereas in a normal person, when you are giving atropine, it produces dilated pupil, it produces tachycardia. They are the signs of atropinization in a normal person. But here in OP poisoning, bradycardia, tachycardia, other things will not work. So here the best way to make a diagnosis of proper atropinization is complete absence of crepitation or dry lungs. That is the sign of atropinization. Now, intermediate syndrome is seen in many patients, around 20% of the cases. After 48 hours, patient can develop intermediate syndrome. Patient can have muscle weakness, progressive muscle weakness, and neuromuscular junction dysfunction. This is due to the release of fat soluble OP agent from the fat. It is deposited in the fat and slowly released from there. Or some patients can develop due to inadequate dose of oxime, pralidoxime. So mainly muscle involved are ocular muscles, neck muscles, proximal limb muscles, respiratory muscles. Patient also can have anxiety, sweating, cyanosis and all. Some patients may develop coma. So this is intermediate syndrome. Delayed polyneuropathy also can occur in some patients who have taken massive amount of OP or the treatment is delayed. This occurs after 1 to 3 weeks of exposure due to degeneration of myelinated nerve fibers. Clinical features are symmetrical, flaccid, distal muscle weakness and foot drop. Absent deep tendon reflexes. Sensory loss all starts in distal part of lower limb, then upper limb also. Now, many books have given pungent garlic-like smell. If we manage OP poisoning, you will be sure that this pungent garlic smell is not there in many patients who takes this OP. They got a kerosene-like or petrol-like smell, more of a petrol or kerosene-like smell, and many patients mix this OP with alcohol. So they have predominant alcohol smell with some kerosene or petrol-like smell. But textbook says that it has got a pungent garlic-like smell. Whatever it is, so the smell will be unusual. You can easily pick up that smell. Now, once you suspect OP poisoning with a toxidrome, you have to always send the patient's blood, gastric secretion, urine for OP investigation, organophosphorus. We have to identify which type of OP is in the blood and urine, and serum cholinesterase levels also can be sent. You can see the cholinesterase level will be low in OP poisoning, but that can be done in a toxicology analytical lab. Now, once you make a clinical diagnosis of OP poisoning, you can send the investigation because of two reasons. One, it is a medico-legal case. Most of the time this type of cases are medico-legal cases, so we have to send the sample for medico-legal analysis. At least if you are not able to send, preserve the samples for future investigation. But most of the time this management depends on your clinical diagnosis. If you diagnose it as OP poison, you have to give atropine and pralidoxime. So take care patient's airway, breathing, circulation. Remove all clothings and clean the body. That is very important because this OP can even after sometimes suppose the patient vomits, it will be spread all over the body. It can even absorb from the skin. So we have to clean the body we have to remove all the clothings which patient is wearing, but we have to preserve these samples for future analysis. If the patient, if the patient becomes a medical legal issue, then we'll have to produce all these preserved materials for police verification. Now, gastric lavage can be tried if the patient come very fast within 1 hour, and some experts say that if the patient had taken large amount of OP, even after 1 hour we can try gastric lavage. That is correct, because it will remain in the abdomen even after 1 hour if the patient had taken a large volume of toxins. You should not try to induce vomiting in any patient who had taken any type of toxins. Activated charcoal can be given 50 gram 4th hourly, 50 to 100 gram initially, followed by 50 gram 4th hourly until charcoal appears in the stool or recovery improves. Okay, so you can give single dose charcoal or multi dose charcoal. Single dose charcoal is always better in a large amount of OP poison like this, but there are some conditions we can give multi dose charcoal. Here it is not indicated. You can simply give one time charcoal around 50 to 100 gram initially. Now, next one is atropine. Atropine is a major treatment in OP poisoning. Atropine reverses acetylcholine induced bronchospasm, bronchoria, bradycardia, hypotension. All these things can be reversed by atropine. Atropine competes with acetylcholine at muscarinic receptors, preventing cholinergic activation. Initial dose is 1 mg IV. If no adverse effects, give 2 mg every 15 minutes until the patient develops atropinization. You should not make a misdiagnosis of atropinization by looking at the heart rate and BP. Heart rate, BP, pupil, all are signs of atropinization in a normal person. But in a person who is having OP poisoning, the sign of atropinization is drying up of lung. That is very, very important. Drying up of secretions in the lung is the most important feature of atropinization in OP poison, whereas in other routine patients it is dry mouth, tachycardia, dilated pupil and all. Now, each 1 ml, each vial contains 1 ml of atropine solution contains 1 milligram of atropine, whereas ampule contains 1 ml is equal to 0.6 mg. That difference you should remember. If you are taking large vials, 1 ml contains 1 mg, but whereas ampule contains 1 ml contains only 0.6 mg. And whenever we are giving atropine, we have to always monitor patient by seeing the monitor whether the patient is going to tachycardia, whether the patient is agitated, anxiety, fear, or patient is making a lot of noise. All these things has to be looked into. That is, we can call it as atropine toxicity. Many patients who have OP poisoning, slowly in second day or third day they go to atropine toxicity. They may have proper atropinization. Sometimes they may not develop proper atropinization. Even then they may go to atropine toxicity. In that type of patients, we can use other types of drugs like glycopyrrolate. Glycopyrrolate is a drug which will not cross to blood-brain barrier. It will not go to the brain. So the agitation, fear, anxiety, or a lot of like uncontrollable behaviors may not be there when we are giving glycopyrrolate. But remember, glycopyrrolate will not cross the blood-brain barrier. So in that, some patients we can replace glycopyrrolate for atropine. We can give only glycopyrrolate. Some patients we may have to give small dose of atropine with glycopyrrolate, so that atropine crosses the blood-brain barrier. It reduces the CNS effects of this toxin, and the toxicity of atropine will not occur, and that part of the dose can be covered by glycopyrrolate. The same dose, same type of dose can be taken for glycopyrrolate also. Each 1 ml contains glycopyrrolate 0.2 milligram. So you can adjust the dose according to the clinical picture. You can increase or decrease the dose according to clinical picture. most of the time we give atropine and add glycopyrrolate. That is the best way to treat OP poisoning, not glycopyrrolate alone. Now oximes, very important drug, they reactivates acetylcholinesterase. But only thing we should remember, that all depends on the time. If the time gap is so much delayed, then that aging will occur. It will become irreversible. That change will become irreversible. So in early phases, pralidoxime has got better results than late presentation. The dose is 1 gram, at least 30 milligram per kg in adult and 25 to 50 milligram per kg for children in 100 ml normal saline IV over 30 minutes. 8th hourly for first 24 to 48 hours. So that is a dose that can be given in OP poisoning, not other types of poisoning. OP poisoning, this is a drug of choice along with atropine. So atropine has to be given, then pralidoxime can be started. Now carbamate intoxication, they are also like atropine. Almost all clinical findings are same like atropine, but they reversibly inactivate acetylcholinesterase. So pralidoxime or other types of oximes are not recommended here. Only atropine infusion alone is enough. So that is the difference, major difference between carbamate poisoning to OP poisoning. Now these are the toxidromes. If you can read about toxidromes, it will be very useful, because this is only a small set of subset of toxidrome. There are a lot of different toxidromes are there. That main toxidromes, it is given here like sympathomimetic, anticholinergic, cholinergic, opioid, sedative, hypnotic toxidromes. There we can see the mental status, heart rate, BP, temperature, pupil size and other clinical findings. In that cholinergic toxidrome, you can see the OP poisoning, somnolence, sleeping, coma, heart rate. We already seen that there is bradycardia, 20% can have tachycardia. BP, it is always hypertension. Some patients can have hypertension. Respiratory rate is increased, lot of secretions are there. Then temperature is, some patients it is increased, not in all. Pupil size is small, and you have to think about the other clinical findings. Sludge, that is the most important, or dumbbells, both you can remember. So we have discussed about OP poisoning, one of the most important and common pesticide poisoning in our country. You should always remember about the major clinical finding. Patient can have increase in all types of secretion. Patient can have fever. Patient can have small pupil. Patient can have fasciculations, and the treatment is mainly atropine and pralidoxime. So that is a very important toxicity in our country. So proper management in emergency room is very, very important. Very rarely some patients can develop respiratory depression. They may require mechanical ventilation. Mechanical ventilation sometimes may be required even after, sometimes initially acutely because of aspiration they may require mechanical ventilation. After 2-3 days they may develop ARDS, then they may require mechanical ventilation. Delayed polyneuropathy period also they may require mechanical ventilation. So mechanical ventilation also may be very, very important when we are managing this type of poisoning. Thank you.